Good afternoon, everybody. We're going to go ahead and get started here. Thank you all very much for joining us here this afternoon. My name is David Griffith. I'm the Director of Programs and Outreach for the LGBT Elder Initiative. We put on this monthly series, The Doctor is In, along with the fine folks at Jefferson, through the Jefferson Center for Urban Health and the Jefferson Department of Family and Community Medicine. So I know some of you have been to some of the past programs we've done as part of this series. Some of you maybe are new to this programming. So just know that we're doing these health topics, a different health topic every month, either here at Jefferson or over at the William Way Center. So we definitely hope you'll come back for future programs on additional topics. A couple housekeeping issues before we get started with the programming today. Hopefully when you came in, you got one of these yellow sheets of paper. It's double-sided. One side just asks some demographic questions, all anonymous, don't put your name on it. We just collect this so that we can report back to Jefferson and other funders and other people who might be interested in what we're doing to know a little more about who's coming to our programs. The other side is an evaluation. Again, all anonymous. That just lets us know what we're doing well, also what topics you'd like to learn more about in the future as we put together the calendar of what health topics we'll be covering through this series for 2019. So those, before you leave today, you can just return those to the front desk up here. Let's see, bathrooms are back down towards the elevators and the stairs where you came in. I think that should pretty much cover it. And again, there is a resource table by the back windows. So at the conclusion of the program today, please feel free to check some of those out. That has more stuff both about the Elder Initiative and Jefferson, but as well as additional resources on the topic of mental health, some of the things we'll be talking about today. So, without further ado, I then want to introduce Dr. Beth Collins, who is a geriatric fellow. Is that still your official title?
I'm a palliative care fellow.
Palliative care fellow.
Yeah.
But has done a couple of these Doctors In programs with us before, and she'll be leading us through the talk on today's topic of mental health. So please welcome Dr. Collins.
Great. Thank you all. I see a lot of familiar faces, but I want to get a sense from the crowd. Who's here for the first time at one of these talks? Great. Well, welcome. Hopefully you'll learn a lot today. I really want this to be, as ones have been in the past, interactive. So I'm going to give my little 2 cents and then feel free to interject or add questions of your own at the end. This is really meant to deliver as much information as we can to you and kind of concerning what you want to know. So when we were asked to talk about mental health, kind of the one thing that keeps coming up, you know, in my practice in geriatrics and in really people of all ages is the topic of depression. So I'm going to be talking primarily about that today. But certainly we're going to touch also on mental wellness, how to keep yourself mentally well, and some tips about how to help somebody who you see is in a crisis. If there are other topics you want to talk about, we can certainly branch off. I'm flexible, okay? So I want to kind of start off by asking, what do you think of when you think of depression? What are some of the things that come up? Yeah.
The continual sadness and feeling as if you're being weighed down.
Yeah, absolutely. Yeah. Sadness and a weight. Yeah. Committing suicide.
Absolutely. That's
Yeah. Yeah. And we're going to talk about that and kind of how to recognize warning signs in yourself and warning signs in others and how to get the help that you need when you're in that place. What else comes up? Yeah.
A feeling of being overwhelmed.
Overwhelmed. Yeah, absolutely. Other things that come up? Yeah. Isolation. That's a big one. Yeah, that's a big one, especially for older adults, kind of as you move away from working and from, kind of from if you had children, moving away from that, moving away from families sometimes, less active and less able to do things. Yeah.
Another is a sense of being bullied because you're not understood, as well as the isolation. You feel as if you're the only person that feels a certain
Yeah,
mindset, so to speak.
absolutely. Kind of feeling like you're the only person going through it.
And that you're sensitive, and you're wondering if you're too sensitive.
Sure, sure. Okay, I think these are all really good kind of starts to kind of get us thinking about what's going on. I know it's not the happiest of topics, but we're going to try to make it informative, if nothing else. So I do want to play this short video that kind of talks a little bit about the science behind depression.
Depression is the leading cause of disability in the world. In the United States, close to 10% of adults struggle with depression. But because it's a mental illness, it can be a lot harder to understand than, say, high cholesterol. One major source of confusion is the difference between having depression and just feeling depressed. Almost everyone feels down from time to time. Getting a bad grade, losing a job, having an argument, even a rainy day can bring on feelings of sadness. Sometimes there's no trigger at all. It just pops up out of the blue. Then circumstances change, and those sad feelings disappear. Clinical depression is different. It's a medical disorder, and it won't go away just because you want it to. It lingers for at least 2 consecutive weeks and significantly interferes with one's ability to work, play, or love. Depression can have a lot of different symptoms: a low mood, loss of interest in things you'd normally enjoy, changes in appetite, feeling worthless or excessively guilty, sleeping either too much or too little, poor concentration, restlessness or slowness, loss of energy, or recurrent thoughts of suicide. If you have at least 5 of those symptoms, according to psychiatric guidelines, you qualify for a diagnosis of depression. And it's not just behavioral symptoms. Depression has physical manifestations inside the brain. First of all, there are changes that could be seen with the naked eye and X-ray vision. These include smaller frontal lobes and hippocampal volumes. On a more micro scale, depression is associated with a few things: the abnormal transmission or depletion of certain neurotransmitters, especially serotonin, norepinephrine, and dopamine, blunted circadian rhythms, or specific changes in the REM and slow wave parts of your sleep cycle, and hormone abnormalities, such as high cortisol and deregulation of thyroid hormones. But neuroscientists still don't have a complete picture of what causes depression. It seems to have to do with a complex interaction between genes and environment, but we don't have a diagnostic tool that can accurately predict where or when it will show up. And because depression's symptoms are intangible, it's hard to know who might look fine but is actually struggling. According to the National Institute of Mental Health, it takes the average person suffering with a mental illness over 10 years to ask for help. But there are very effective treatments. Medications and therapy complement each other to boost brain chemicals. In extreme cases, electroconvulsive therapy, which is like a controlled seizure in the patient's brain, is also very helpful. Other promising treatments, like transcranial magnetic stimulation, are being investigated too. So if you know someone struggling with depression, encourage them, gently, to seek out some of these options. You might even offer to help with specific tasks, like looking up therapists in the area or making a list of questions to ask a doctor. To someone with depression, these first steps can seem insurmountable. If they feel guilty or ashamed, point out that depression is a medical condition, just like asthma or diabetes. It's not a weakness or a personality trait, and they shouldn't expect themselves to just get over it, any more than they could will themselves to get over a broken arm. If you haven't experienced depression yourself, avoid comparing it to times you've felt down. Comparing what they're experiencing to normal temporary feelings of sadness can make them feel guilty for struggling. Even just talking about depression openly can help. For example, research shows that asking someone about suicidal thoughts actually reduces their suicide risk. Open conversations about mental illness help erode stigma and make it easier for people to ask for help. And the more patients seek treatment, the more scientists will learn about depression, and the better the treatments will get.
Okay, most of the time I think people say things like, I understand what you're going through out of love and wanting to create connection with you, but sometimes that can hurt. So we'll talk a little bit about sort of the ways you can kind of confront somebody or talk to somebody who's going through a crisis in ways that are healing, essentially. So to kind of go through a little bit about some of the things that were touched upon in the video. So depression is different from kind of the day-to-day fluctuations in our mood that we all have. We all, may feel slightly happier or slightly sadder depending on the day, depending on the weather, what's happened in our lives, where we are kind of personally. But depression is different. This is something that causes symptoms severe enough to affect our daily functioning. And that's really what makes it a mental, quote, illness versus something that's healthy. A sadness or grief or things like that are healthy and quote, normal. So to have depression, according to kind of psychiatric guidelines, you have to have feelings or you have to have symptoms that are present nearly every day, most days, most of the day, and then at least for 2 weeks, okay? So this isn't a passing sadness. It's really a persistent thing. There are a lot of different kinds of depression. These are just the 4 of the more common ones, and especially in older adults. So major depression is sort of what people think of when they think of depression, or clinical depression is a word people use a lot. Persistent depression disorder, which is also called dysthymia. The way we all learned it in medical school is sort of the Eeyore character, somebody who's kind of mildly down all the time, and that's sort of that is a form of a depressive disorder. Seasonal affective disorder, as anybody who struggles with this, as the seasons change, this can really kind of flare up, and that's also something to be categorized under depression. Bipolar disorder is a mood disorder. It's characterized by both those lows but also highs and kind of moods that can fluctuate. It's also known as manic depression, and that's often what it's referred to. So what causes depression? The big thing is we have no great idea about it. We have a lot of clues, but like a lot of things in medicine, and I feel like we've talked about this before, there's no single answer that really contributes to it. Yeah.
I was going to say, many people have done a little bit of research. If you have an issue with drinking, it's allegedly a depressant. It might not leave a person suffering or dealing with depression, but it does play a risk and a factor. With me, it was mostly environmental.
Yeah.
I was bullied in school, and then I came home and got more of it.
Sure.
So it could be a myriad of things. Like people are different. The same thing for the depression. A lot of people don't realize that.
Yeah.
There could be chemicals that you don't even know you're ingesting from tap water. You have no idea what the true root is.
Yeah, and we'll talk a little bit about that, but definitely it's things that come from internally, so genetic predispositions, family. If our parents were depressed or struggled with mental illness, we're more likely to.
My mother's bipolar, so I can understand that.
Okay. And certainly environmental factors, medications, drugs and alcohol has came up. That's a big one. Other illnesses, especially as we get older, that can contribute to things as well. Life itself, isn't that the truth? Yeah. And kind of depending on what kind of situation you're in your life. Absolutely. So what are some of the signs and symptoms of depression? These may sound kind of obvious, but sort of when we're diagnosing somebody with depression, this is something that we think about. So first of all, to qualify to have depression, you either have to have a depressed or down mood or a loss of interest, something we call anhedonia, or loss of interest in things that you used to find pleasurable. And then in addition to one of those two, you have to have a couple other things. So either a change in weight or appetite, so that can go up or down, a change in how much you sleep, too much, too little, slowing down or kind of getting more agitated and irritable, losing energy, feeling worthless or guilty about things, not being able to concentrate or make decisions, and then finally, thoughts of suicide or death. Okay. Yeah.
Okay, my therapist used to tell me that I was going through a depression because I like to be by myself a lot.
Mm-hmm.
A lot. But I told him, how can that be a sign of depression? I said, when I'm out most of the day around people.
Mm-hmm.
I mean, it's not
And
fair
that's
that I
what's
get
different,
to be
right?
to myself sometimes.
Yeah.
You know? So he said, you shouldn't isolate. I said, I don't be isolated. It's called me time.
Right. And there's a fine balance.
Yeah, he still couldn't understand that. I don't know.
Because I think what's important in depression is, and maybe this is what he was thinking maybe you were going through, but I think what's important in depression to know is that depression makes you want to stay by yourself and do the things that aren't good for you. So depression makes you want to continue sleeping, makes you want to stay in bed, makes you want to stop talking to people, cut yourself off, when in fact those are the things that can help make you better. So, yeah. So when we talk about depression, we were kind of talking about depression at large, but what makes depression different in older adults? So a couple of things. Most importantly, as all of you know who are into your older adulthood, life stressors are different, just as they were when you were toddlers and you were trying to figure out how to walk and how to navigate the world. Some people in older adulthood are facing retirement, kind of moving out of the workforce. Some are moving home, so maybe the place where they were living became too much for them and they needed somewhere more comfortable, or they're moving to an assisted living facility or a nursing home. Isolation and loneliness, that's a big one, especially in older adults who identify as LGBT. What's that? Yeah. Getting older in general, right? Losing kind of physical capabilities. Financial difficulties that come with getting older. Losing friends, family members, partners, and loved ones. Regret. So this is a big thing that comes up at the end of people's lives or as they get older, kind of looking back through your life and thinking about things you might have done differently. Existential concerns, what happens from here? That's a big question that most people face as they get older. And facing your own mortality. These are really uplifting topics, guys, so thanks for sticking with me. Yeah. Right? I know, if you weren't depressed before.
Also, it's not just being depressed, also too, it's fear.
Absolutely.
And fear also adds to depression, because then
Absolutely.
you just ready to just either give up, because like a person can be stuck.
Yeah.
I mean by stuck, I'm not talking about far as using drugs, I'm talking about in that situation.
Yeah.
They want to move forward, but they can't move forward. And there's something that's in the way, they get more depressed and they make their own self stuck more.
Right. And that's the tricky part about depression, right? Other things, when we feel pain from stepping on a nail, we know to stop stepping on nails, But depression, when we feel that, our body's telling us to keep doing what we're doing and isolate and kind of wall ourselves off from the rest of the world, and we can get stuck. And you're absolutely right that anxiety, that fear, that worry about uncertainty in life, that goes hand in hand with depression. It's hard to kind of extricate those two things. So older adults are more likely to have their depression also mistaken for other things. So things like dementia. Oftentimes people have issues with concentration, trouble making decisions, trouble with memory. And people think that's either normal aging and losing memory. And some people even get misdiagnosed with dementia because of it. Parkinson's disease, and oftentimes depression is part of Parkinson's disease. Thyroid disease, same thing. These are kind of things that kind of live together oftentimes. And then often people think of, and diabetes, absolutely. And often people think that's sort of a normal response to just getting older, which it shouldn't be, you know. We all face times when we feel sad about getting old and feel regret about things in our lives, but depression is something more, okay? So other ways that depression is different, older men we know, especially older Caucasian men, have the highest rates of suicide, honestly, of anyone. I think oftentimes we think of younger people struggling with suicidal ideation and suicidal thoughts, but unfortunately older men are the ones most likely to carry it out. And a lot of people don't realize that. Yeah. And often depression doesn't always look like what it does in younger people, in older adults. So a lot of times it won't come in as sadness, as as sort of what we think of as laying in bed and crying all day. Sometimes it'll come in as, I just can't make a decision, I can't focus, I'm forgetting things, I don't want to go out and do the things that I used to do. Weight loss is a big one. People who just aren't able to kind of, maintain their weight. Apathy or sort of loss of interest in doing things. And then physical pain, right? As we get older, there are a lot more reasons we have to have pain, and a lot of that can tie in. We know that pain and depression are intricately related. And then often people are more likely to have physical illnesses like the ones we talked about before, but also things like stroke and heart attack that are more likely to cause depression. And then people are more likely to be on medications that cause depression. And some of those are needed, and some of those it might be worth talking about getting off. So, any comments so far? Yeah, I thought I saw some hands.
I have a question, or you want me to wait till later?
No, go for it.
Well, the question I have, all right, especially for instance, you love someone, okay? It could be a spouse, family, sister, brother, whatever.
Yeah.
And they're going through that, and you see it. But
Yeah.
then you'll see them like in the same room you aren't in, but you see them like depressed.
Yeah.
And you care about that person so much. Can't that also lead to me to be like that too?
Absolutely.
Run into that though? I mean, when I'm running, I'm talking about as far as me getting to that stage as far as being depressed.
Yeah.
I mean, and it gets more serious. So
Yeah.
how can I prevent that from happening? I mean,
Yeah.
is it the
And
person be what they...
Sure, and we'll talk a little bit about that in a couple of slides about sort of how to keep yourself well while you're taking care of others.
Okay.
But nobody's an island, right? As much as we'd sometimes love to be, like we're all affected by how other people act, Yeah.
That's what I was just about to ask you, is if you meant like you feel depressed because you can't help them get out of their depression. Is that what you were asking? Yeah, because I noticed that my mother with her bipolar, I don't know if it was something that was tied into my situation because of genetics, like she had spoken of, but I think the fact that my mother didn't understand me was the factor for me to be depressed. And then I was sitting there trying to research and do more to find out from people what they meant when they felt depressed. And I try and talk to people who have dealt with it so I can understand, okay, well, what are you going through? I want to be a listening ear. Sometimes that helps, and if you have a listening ear too, that also could help. I don't know if it'll definitely work for you.
If they talk.
Yeah.
Yeah, it's tough to get people to engage, for sure. So medication, and I'm going to throw up some names that I kind of put the generic name, the name that sort of doctors and pharmacists and nurses use, and then the one you might have heard of from the press and kind of the literature. So antidepressants are sort of the main go-to medication for depression, surprise. The biggest category of medications is called SSRIs, which stands for selective serotonin reuptake inhibitors, which is why we call it SSRIs. These are things like Prozac, Zoloft, Celexa, Lexapro, Paxil. These are the ones we know work. We have the best evidence that these work in depression. So not all the time.
Okay.
Definitely not all the time. In fact, only about half of the time.
The Zoloft, okay, they told me in my drug and alcohol program, this is
Okay.
what they told me
Uh-huh.
to go and seek a therapist. That way, it'll eventually get me my housing faster. Okay, so I called myself following their advice. Went around there. He told me I had mood swings. I said, life is a mood swing, so what is the point? And
That's the truth.
prescribed me Zoloft.
Yeah.
I took one pill, and it got me high. And I said, oh, hell no.
Oh,
I didn't
man.
come in here to trade one drug for another.
Yeah.
And I see them in the toilet.
Fair enough.
And I never let him prescribe me any. I never went back.
Yeah.
I didn't come to trade one drug in for another.
Yeah. No, I hear
I
that.
never went back.
I hear that. I think medication is tricky because for some people it works very well and people can get their life back with medication. But in other cases, people have terrible side effects like you have.
Yeah.
Yeah.
I wanted to mention with Prozac,
Uh-huh.
number one, I did not feel better because, the main thing I got was nausea. I said, if I don't want to be nauseous, I'll just stop taking my insulin, go into DK. I'm not doing it. And
Hopefully you
I'm
would
still dealing with
do that,
my
yeah.
mother, who didn't understand me, wanted to control me because she treated me like a diabetic, not a child with diabetes. And there's a difference.
Yeah.
It's hard to find the right depressant. It's trial and error.
Yeah, absolutely.
And sometimes they combine them and they have to play with them to get the right combination.
Absolutely. So I would absolutely urge people. I know that a lot of people are hesitant to try medications, but I've seen these medications work, and I am not somebody who likes medication. So I would encourage you to go and ask about them and see what's right for you. Because a lot of the time, one medication might not work. You try another. It's sort of a trial and error thing. Yeah. Sorry, you had your hands up.
Okay. The question about Prozac, when it first originally came out many years ago,
Yeah.
there was people who committed suicide off of taking that.
So that's
particular
that's something that I kind of thought might come up.
when it first came out.
So I'm happy to talk about that. I got a little spiel on that. So kind of some of the things that people think about, a lot of people have heard about that SSRIs can increase your risk of suicide. So medications like Prozac, things like that. First of all, there really is only good evidence that might be the case in younger adults. So in teenagers, in people up to about 25 years old. In people kind of in middle age, 25 to 65, it doesn't seem to affect the suicide rate. And then 65 and over, we know it reduces the rate of suicide, okay? So that was something that I think we saw in one study, and it was sort of, we took it and ran with it. And I think I've heard from different people, and I'm not a psychiatrist, so I don't want to say this with absolute authority, but a lot of people have said that sometimes what can happen is that these medicines are given to people who don't have depression but have bipolar disorder, and that sometimes those medications can actually ramp up the kind of mania part of their bipolar disorder and cause them to do impulsive things like hurt themselves. So that's kind of why it's important to see a doctor to get these and why we're not giving them over the counter, but I hope that clarifies things a little bit.
I don't remember the name of one, but I get a chance, thank goodness, to watch Anna Restless on my phone, but there's always this commercial where it has this lady with this happy face, and I don't remember the name of the medication for the life of me. And it was stating something about taking it along with your depression medication. And
Maybe
I'm like, okay,
Abilify?
maybe that's it. I don't
Yeah.
remember.
Big one that
Yeah.
people
But I'm like,
hang on.
okay, a lot of people if they are experiencing symptoms, if you're depressed and you want to lay down and sleep, most likely you're going to just lay down and sleep instead of get up and take your medication, along with a new one that is supposed to help it. you know. So
And that's
it's a
what's
balancing act.
tricky, absolutely.
Mhm.
Yeah, go ahead.
Well, I mean, the scary part of the balancing act for me is I'm kind of sick with that. It's why am I trading a drug that I know put me there for some that we got to play trial and error with to make sure I don't go back. And what will happen if I do?
Yeah.
Since I already know what will happen if I do, why am I? Why am I
And
going
I think that's the importance of your doctor and your therapist talking to you as a person instead of, you know, looking largely, because I know a lot of people that this has honestly worked, that those medications have worked well for, including people with a history of drug and alcohol use disorder. You know, but on the other hand, it doesn't work for everybody. And a lot of people have kind of, you know, we talked about all those things that cause depression. This is really good at treating sort of those imbalances in your brain. It's not going to solve your divorce. It's not going to solve your loss and isolation. It's not going to solve things like that. So, right. Which is why I do want to talk about kind of the other component of treatment, which is psychotherapy, which I think is really important. Yeah.
I take one of those that does and has been working for me. I'm certainly grateful for that.
Good.
And if there's certain times when I get down, what helps me is just being with people.
Yeah.
I mean, sometimes I'll rest, but just being with people. Or sometimes at home I'll put on music. So you just feel like you learn what works.
Yeah, absolutely.
And I have a good therapist, and she knows about what not exactly, but what my income is, and she charges me really low amount.
Good.
So grateful for that too.
Good. Because I mean, talk about trial and error. Finding the right therapist is sometimes a lifelong endeavor, right? Okay, go ahead. Yeah.
Can you talk about the SSRIs versus some of the antidepressant or anti-anxiety medications?
Sure.
Like Valium?
Sure.
So how do they interact, or what's the
Absolutely.
difference?
So medications like Valium, Xanax, Ativan, Klonopin, what else am I, Restoril, all of those medications are in a category called benzodiazepines. Those medications are great for kind of panic attacks and anxiety in the moment. They're really terrible for anxiety over a long period of time. These are actually the medicines we prescribe for anxiety. So medications like Prozac, like sertraline or Zoloft, those medications are really what we go to for anxiety. The other thing to know about medications like Valium, Xanax, Ativan, they can cause an increased risk of dementia, of confusion, falls. They're really like a no-no drug in people over 65. So.
Okay, the ones you just mentioned.
Not always. Sometimes they're appropriate, but usually.
I thought they were for pain.
No, they're for anxiety. And oftentimes they can be, medicines like Valium can be treated for sort of muscle spasms or seizures even, because they all work kind of on your brain. But no, they're typically used for sort of that acute anxiety reaction.
Because if I'm
Or
not
seizures.
mistaken, one of them you just mentioned, my doctor sure prescribed it to me for pain. I took it once, it didn't do anything, and I told her, I fussed her out about it. I don't why do you keep giving me something that doesn't work?
Good. Well, I'm glad you didn't keep taking it, because I'm not a big proponent of keep taking things that don't work. So yeah, go ahead.
Benzodiazepines are also highly addictive.
They are absolutely highly
It's
addictive.
hard to get off them too.
Absolutely, yeah. And they're dangerous to stop cold turkey too. So if you are on them, please talk to your doctor before stopping them. Yeah.
I was gonna say, even though, like a lot of times I like to sleep.
Yeah.
And when it's hot, it's summertime, you're depressed. That's what my mother thought. And I'm like, no, it's just hot. I need breath.
Sure,
And
right.
then,
It's hard to know.
it's not to say it works for everybody. Sometimes, like she was speaking about music,
Mhm.
any type of therapeutic art. Like I write poetry.
Yeah.
And my mother says, well, your poetry is good, you should get it published. And I thought, if she only knew this poem was about her.
Oh no.
But, you know, even if you can find something that's not necessarily a drug, and then that really
Absolutely.
offsets it even more,
Right.
try it. If it's, you have to take a rest for as long as you can.
Yeah.
You know, as long as
Yeah.
you're not going into, well, let me drink myself because
Right.
it'll make me numb.
Right.
And then it'll also do more depression
Yeah.
type of situations. Anything that can work, try it. You
Right.
know? That's not going to do more damage.
Absolutely. Anything that isn't a medication, you know, is often usually has fewer side effects. So I want to just make sure we're moving along so we cover a couple other things. Go ahead. One last question. Yeah.
The short part about Prozac. But Prozac originally was also given out for rheumatoid arthritis.
It was?
It was, and that's where they first come out with the word the suicidal thoughts.
Oh.
So those were the people. 'Cause
Okay.
My mother had taken it back.
I was not aware of that, but could be. Just a couple of other things before we move on about medications. So one thing is they're not medication, unlike the benzodiazepines that we were talking before, like Xanax, Valium, Ativan. Those aren't medications that you should take every day. These medications are something you should take every day no matter how you feel, because they can take weeks to start working rather than work as soon as you take them. And you can get them from either your primary care physician. I would say all primary care physicians usually feel comfortable prescribing these medications, or from a psychiatrist. And then we talk about psychotherapy, which is really a way of teaching new ways of thinking and behaving and changing habits that contribute to your depression or your mental illness. So it helps you to understand and sort of work through difficult situations that might be causing your depression or making it worse. And a lot of people get therapy and usually think of therapy as individual therapy, but it certainly can be provided in a support group setting, in couples, in family therapy. It's usually provided by a psychiatrist, a psychologist, a social worker, a counselor. And just to kind of clarify that. Yeah, go ahead.
Sometimes medication doesn't work because if you take medications a long time for depression or for pain, you get immune to it, so your body won't take it. But
So
what I do for depression and pain is I crochet. And
Oh,
it
that's
takes
great.
My mind
I
off
love that.
Of the pain or the
Yep.
stress or the depression that I had.
I love it.
And also
Poetry, crochet, meditation. That's
Yes.
wonderful.
You meditate a lot. I don't know if it'll work for everybody, but I know it works for me.
You gotta find what's right?
Yeah,
Like
that's
you
what
were
it
saying,
is.
you like being around music and
Yeah,
other
all of that
people.
stuff.
Absolutely, yeah.
Okay, you were saying that your primary care physician can prescribe the medication.
Mm-hmm.
So that means if you're already on it.
So usually they can start those medicines for you.
How? And they're not a psychiatrist.
They're medications that primary care providers feel pretty confident prescribing. There are always exceptions to that rule, but I'm a primary care doc. I prescribe them, I promise. Sure, go ahead.
What's the medicine you said? Benzodiazepines. Like Valium, Klonopin, what was the other?
Xanax is a big one, yeah. They're, yeah. So what should you do? And I'm not talking about kind of feeling down once in a while. What do you do when you feel like you're in a crisis? Sure.
Me myself, I get up. Me myself, I get up like for me.
I thought there was really.
I know. I thought there was a cat.
I'm like, wait a minute. I know
I thought
loving
my
my
medication was
kidney.
kicking in.
Oh boy! All right.
I was loving my kidney and ended up escaping. I'm like, huh?
And I didn't.
Go ahead.
It's okay.
Right, as far as the health crisis to me, it's like I'll go like in the morning. I'll get up like about something after 5, off the prayer, okay, and I'll go back to sleep. Or sometimes I don't. I'll stay out with the wife. Or
Yeah.
whatever. But it's just that the fact that first thing that comes to my mind when I wake up sometimes, like fully woke up. I mean, like
Okay.
I'm up for the rest of the day.
Yeah.
It's money. Okay, that's a health crisis right there.
It is.
Okay,
You're
and
absolutely
it's like,
right.
and then I stop and I think spiritually.
Uh-huh.
Okay, what helps me?
Okay.
All right, is that first of all, I'm woke, I'm alive. I'll be able to do this, do that, do that.
Sounds
You know
like
what I
you
mean?
have
But
really
I also
healthy
passes
ways
it
of
on to-
coping.
Huh?
It sounds like you have very healthy ways of coping.
Well, yes.
I mean, I
it
know
helps,
it's-
it helps, but it's kind of hard to discipline myself to stay in that frame of mind.
Yeah.
Because once I go out them doors and I'm in society and I see certain things, it's like kind of like a struggle.
Yeah.
You know?
I get that.
But other than that, I mean, I try to also pass it on to others around me, right? And that, you know what I mean, they feel the same way too.
Good. Good. So, if you need help immediately, yes. Exercise, absolutely. And we're going to talk about that as a way. Maybe you've seen a theme if you've been to more than one or two of these. Exercise tends to be an overlying theme of keeping yourself healthy. It's wild. I wish I had a pill for that, but we don't. Oh, wonderful. I love that. That's good kind of for anxiety control as well, for some of the meditation that's built in. So I want to point out this. This is the National Suicide Prevention Lifeline. And I want to take a second, and I want everybody to pull out their phone if they have a phone or a piece of paper, and I want you to put this number in your phone, okay? If not for you, for somebody else. Yeah. So you can put this number in your phone, and you can call them even if you have a concern about someone else, okay? So the number is 1-800, can everybody see it? 273-8255. Okay, and I can put it back up at the end too. Okay. Okay. And then if you're feeling that low, other things to do, call 911. They'd rather you do it and you know, have a health professional talk you through a time like that. Or go to the nearest emergency room. Right? If you're feeling acutely unsafe, they can help by protecting you from yourself. Yeah, this is not something when you're feeling depressed and you just need something. That's not the time to go to the emergency room. That's a very good thing to point out. Oh, I bet. Yep. Yeah. You gotta be at the end of your rope for sure. So one thing I was wondering about, maybe you were too, is what happens when you call the suicide hotline. So actually, when you call, you'll hear a little automated message giving you options to try to route your call. It's very quick, very fast. You can go through and get to a person. But there are, yes, yeah. And then somebody who will talk to you will talk you through whatever crisis you're going through. So this is really something that they've tried to centralize. There are a lot of sort of disparate suicide helplines, and this is kind of a national effort to get things together into one line.
Did they do that because they never really got that many calls? So
I think they were getting a lot of calls, and everybody was doing it a little bit differently. So they wanted a way to do it so that they knew that it worked and they were doing it the way that they should be doing it. Yeah.
I don't remember about the answer servicing part.
Yeah. Just press 0. Yeah.
But somebody can be in a crisis and may not have that attention span to press 0.
Yeah. Fair enough. Yeah.
They want help.
And they're working on it every day. So, what do you do if you're looking for a therapist? How have people successfully found therapists? If you're okay sharing? Yeah, online. Okay.
Ask my friends.
Ask your friends, for sure. That's a good one.
I've learned to be my own therapist by doing the poetry.
Okay.
And other people, God bless them, that can find a therapist that works for them. That's great. But if you're writing down things about me and I can't see, that's not just plain old nosy. It's just, if you're writing about me, I need to know what you're talking about or writing about.
Fair
or
enough.
are you over there doodling Mr. and Mrs. XYZ
Right.
forever?
Right.
Like, I need to know this.
Yeah. And I think it's important to kind of find that fit. If that's really disconcerting, you can find therapists who don't take notes or are very upfront with you about things. It's all sort of about finding what works for you. And usually that's not on the first date. Yeah. Go ahead.
In Philadelphia, there are community mental health centers, and they'll work with you on the
Yes,
fees.
absolutely. And that's something I wanted to make sure we pointed out. So if you don't have health insurance, community mental health centers, we're lucky to live in a city that has a lot of resources, even though sometimes it doesn't feel like we have enough even still. For mental health care, you can go to a federally qualified health center. I know there are some resources in the back if you need help with that. There are a few sort of databases of therapists as well online. Those are some of the ones that I'd recommend, and we can give you more information in the back as well about that. Use your support network, right? Like we were talking about, depression is really one of those diseases that makes getting well even more difficult because it makes you do the things that keep you sick. So reach out and remember that, think about yourself having a friend ask you for help. You want to help. Generally, people are good. I like to believe that anyway. Sometimes I question it, but I think generally people want to help and want to provide assistance to you. So remember that. Remember, you're not a burden. This is something that they may need to ask you for help in the future. So I want you to think about something called a mental health safety plan, okay? And this is part of something called mental health first aid, okay? This is sort of the CPR for your mind, okay? If you think about that. So a couple of things, and this is when you're feeling okay, that I want you to think about doing these things. Recognize the signs that a crisis is coming up, okay? What sorts of things set you off? What sorts of things make you sad? And then list the things that you can do, be it being around other people, yoga, music. We talked about a lot of them, crochet, poetry. Bike riding, wonderful. Exercising, sex, great. There you go. There you go. And it is, you're absolutely right. It takes your mind off a thing. If you list some of the places where you can go to feel safe. So does that mean alone in your apartment? Maybe, probably not. Only, right. And only if you feel like you're safe there. Maybe it's at a friend's house. Maybe it's just in a coffee shop. Maybe it's outside in a park. Somewhere to feel safe. And if you're really in crisis, maybe that means a hospital.
If you can't dance and you know you'll get criticized, dance by yourself when nobody's watching.
There you go. List people you can contact when you're feeling unsafe, okay? Or pets, absolutely. There you go.
I'm sorry, but furry little animals with
That's true. Sometimes they're a lot better than any human connection. I get you. List professionals, people who do this for a living that you can contact. Be that your therapist, an emergency room doc, your primary care doctor. Put the Lifeline number into your phone, and we can leave that up for you to do again. And then think about ways to make your environment safe. So that might mean taking guns out of your home. That might mean taking drugs and alcohol out of your home so that you make it a safe environment. Taking bad, absolutely, absolutely. Taking sharp objects away sometimes. They're all, you know what works for you. Okay? So somebody brought this up. What can you do to support someone who's going through a mental health crisis themselves?
Listen.
Absolutely. First and foremost, listen and reserve judgment. Because like somebody was saying, you can't be in their brain. You can't know exactly the nuances of what they're going through. And let them know you're there. So say something kind of non-confrontational, like I'm worried. Can we talk? Okay?
But a lot of times when you do that, you try to talk to somebody about something that you're going through, you tell them not to do certain things to you or say certain things to you. And they do it anyway just to aggravate you. And that's,
Isn't that that's the beauty of, that's why you find furry friends sometimes, because you don't have issues with that. Unfortunately, people are people, and sometimes it comes from goodness, but hopefully it does, but not always, right? And remember,
for everybody, but sometimes just a hug.
Absolutely.
No.
Sometimes words aren't right. Yeah.
Not everybody's a hugging person.
Right. Right.
So,
right.
If you want to bring it in, bring it in. If you don't want to, my breath is stinking right now.
And remind people that depression is not a mental illness, right? Normalize depression. If you've gone through your own struggle with mental illness, I'd encourage you, if you feel comfortable with it, to talk about it to them. Getting rid of the stigma is really what brings people to help, okay? If we all make it normal, then we all know this is something we all could potentially have. This is not a weakness. This is not a shortcoming. This is not a lack of will for trying to come over something. Any more than somebody can will themselves out of a diabetic crisis or out of an asthma attack.
For me, right, I don't feel like after I ask the individual, you okay?
Yeah.
Right, and you'll see it on their face that something's bothering them, but they'll say they're all right.
Yeah.
But then me myself, I don't feel. What's that word I'm looking for? Comfortable with the answer that was given back.
And that's tough. Because like I was saying, depression makes you say things like, I'm all right. Depression makes you say things like, I don't want to go out. And makes you stay at home and make yourself sicker. Right. It's tough as someone who loves them and wants to help them. Absolutely. So some practical ways to help. You see somebody in a crisis. Here are some things to think about doing. And this, I want to kind of, this is a conversation with the person who's going through it. This isn't something you want to sort of push on everybody. But make a list of nearby therapists or doctors that they can go see. Offer to help and call to make that appointment. Even that step can seem enormous to someone with depression. Go with them to the emergency room if they're in that kind of acute crisis. Tell them that you're on call for them whenever they need it, okay? That you're sort of that emergency contact for them. And then, again, like I was saying, tear down the stigma of depression. If you feel comfortable sharing your story, share it. It helps, like anything else, kind of bringing the experience out of the closet, in a sense, really kind of helps people talk about it and helps normalize it. So how can you preserve your mental health? Just quickly. Exercise, somebody said. Eat healthy, unprocessed foods, things like avoid drugs and alcohol, especially when you're feeling low, which is, I guarantee, the time you want to use them the most, okay? Especially if you struggle with a substance use disorder. Get 7 to 9 hours of uninterrupted sleep every night, if you can. God bless you. Practice. That's the goal, baby steps toward it. Practice deep breathing and relaxation and meditation.
You're missing something.
What's that?
Sex.
Sex, all right. Good for you. I agree. I think that belongs up there. And then, yes.
But that should be up there too, right?
Yeah, right, absolutely. Everybody has their way to do wellness. And wellness, there you go. And reach out to others for support, okay? Again, no person is an island. This is kind of when you need to reach out. So here are some resources. I'll just leave this up for a second. Any final questions? I think we're about at the end.
I
but
have one.
Sure.
Now, let me ask you this. I'm not depressed. I mean, I'm not going through that stage. Thank God.
Thank
Thank
goodness.
God.
Yeah.
But it's just that I'm getting older too, and I keep thinking that, you know what I mean, that I'm gonna be going through that menopause thing, all that stuff, right? But it's just that the fact that now, because you may be with someone that may be going through that, is it a good idea or not for a person that's not depressed to have a therapist also?
I have never seen anybody who couldn't benefit from therapy.
I'm not talking about the person that may be going, that is going through depression.
Right.
I'm talking about the person that's not.
Yep, me too. I agree. If you think that having somebody to talk to and talk kind of and give you feedback that is maybe, you know, that doesn't come from a place where they know your business, or know kind of the circles you run in, or know sort of all about you, kind of an unbiased opinion, I think most people could do well from that.
That'd be helpful.
Yeah, yeah, yeah.
On Friday nights, the William Way Center has trained people that
Oh,
folks can
wonderful.
come and talk to.
I didn't
In
know
person,
that.
or
Thank
by
you.
phone. Yeah.
Okay.
And people that have been around for quite a while.
Wonderful,
Yeah.
wonderful. And I know there are a lot of resources on the back table that I want to direct you toward
And
also.
you also have
Yeah.
to be careful about who you touch business to.
Isn't
because
that the
a lot
truth?
of times people use that against you.
Yep.
And they go into other people, and
Yeah.
I really think that's wrong. If you feel though this person is confident, you have confidence in this person that they would keep your business to them, between you and them, sometimes it don't work that way.
Yeah.
And that's what you have to be careful with.
That's for sure. Yeah. It's like anything else. You gotta know who you trust, who you can trust. Okay.
Even if you have a diary
Yeah. Even a diary sometimes can help.
or
Yeah.
journal, however you like to post it.
All right. I think we are done. So thank you all so much for coming. We'll be here for a little while asking some questions or answering questions if you need.